Good evening, all. Let me again congratulate Aditi Jitendra team for this wonderful organization of events and also the ClearNet for giving us all the support. So after the first session on the physiology of kidney functions, it was a wonderful session. We are now proceeding with the evaluation of kidney function, assessment of kidney function, and how we will be able to understand from the clinical picture as well as utilizing the panel of investigations that are available, we will be able to reach diagnostic conclusions. And so for presenting this, we have got Dr. Christy Catherine Thomas, who will be giving us an overview of the assessment of kidney function, and Dr. Abhijit Saha giving us the case presentation pertaining to the evaluation of kidney functions. Dr. Christy Catherine Thomas is working along with me as assistant professor in Department of Pediatric Nephrology at SAT Avittam Tirunal Hospital, Government Medical College, Thiruvananthapuram. She is an alumni of AIIMS Delhi. She has done her DM Pediatric Nephrology from AIIMS Delhi, trained under Dr. Bagga, Dr. Aditi, and Dr. Abhijit Saha is currently the professor of Pediatric Nephrology at Kalavadi Saran Hospital, Delhi. And he is also having a very nice pediatric nephrology department and a long innings in pediatric nephrology. So I'm sure both these faculty members will be able to give us a great lecture as well as case discussion on the evaluation of kidney functions. And over to Dr. Indira for a few words, and then we can proceed with the presentation of Dr. Christy.
Yeah. Good evening to everybody. I think Dr. Susan has already introduced all the speakers, and welcome to all the delegates as we look forward to another evening today, interesting evening with we are today going to talk about assessment of renal function, which is an extension of the previous topic of last week. And I hope after this session, you'll have a little clearer understanding of whatever we can do in the time allotted. I hope we will be able to give you a better understanding of the actual assessment of kidney function. So without wasting much time, we'll move over to Dr. Christy, who will give us the sort of the, the actual assessment, the theory behind it. And Dr. Abhijit will actually try to give us through a few cases, try to show the application of this topic and help you to have a better understanding. Thank you. Over to you, Christy.
Thank you, ma'am. Is my slides visible?
Yes, Christy, they are
Yes.
visible.
I hope I am audible clearly.
Yes.
Okay. Thank you. At the outset, I would like to thank the organizers for having me. And the first session, the first class of today's session is assessment of kidney function. So in this topic, we'll see how will we assess the kidney function. What is the difference between EGFR and MGFR? How will we calculate EGFR and MGFR? Which option should we select for a particular patient to measure GFR? We'll also see an overview of tubular function, and we'll see what are the stress tests for glomerular and tubular function. Kidney being an excretory organ, the major function is to excrete metabolic waste products. It has role in homeostasis also. So it helps to maintain water, pH, electrolyte balance. It has some endocrine function also. So it helps in the production of calcitriol, renin, and erythropoietin. So by the term assessment of kidney function, your aim is to detect presence of renal disease and also to monitor the response of kidneys to treatment and so to determine the progression of renal disease. Ideally, when you say assessment of kidney function, you should assess all the functions of the kidney, the excretory function, the homeostatic function, and the endocrine function. But when you see a patient in an OPD or in ward and you say that the patient's kidney functions are normal, you imply that the one particular function of the kidney is normal, that is the glomerular filtration rate. Usually, we refer the entire kidney function as single function, that is the glomerular filtration rate. The GFR is the most useful general index of renal dysfunction. It is sum of average GFR of all the nephrons. It's a direct measure of kidney function, and it is reduced before the onset of symptoms. Detecting decline in GFR is important because it correlates with the two other functions like tubular function, endocrine function, and metabolic function. If there is dysfunction in any of these domains, decline in GFR correlates with this. And it is associated with many physiological and clinical consequences like biochemical complication, uremic symptom, and it also correlates with the extent of pathological finding, especially in cases with chronic kidney disease. Accurate GFR estimation is essential since that leads to early detection of AKI, to monitor medication-related nephrotoxicity, to make dose adjustment for medication, and to perform risk assessment before drugs or contrast, and also for staging CKD, and also for monitoring its progression. So how will we measure GFR? As Dr. Sudarshan has described GF clearance in his applied physiology class. Clearance is the volume of the plasma cleared of a substance in unit time. Suppose you have a steady state and in balance. If we have a particular molecule with constant rate of production, no hepatic clearance, no renal metabolism, something which is not reabsorbed or filtered, the clearance of that substance can give us glomerular filtration rate. And the blood level of that substance will be inversely related to the glomerular filtration rate. These molecules include the creatinine, cystatin C, and the beta trace protein. And these are otherwise called the endogenous markers of glomerular filtration assessments. These endogenous markers will help us to derive the estimated GFR or the eGFR. We can introduce some molecules, and from the calculation from them, we can have the measured GFR or the mGFR. These molecules are called exogenous markers, which include inulin, radio-labeled or non-radio-labeled molecule. They should be non-toxic, inert, freely filtered, not plasma protein bound. From the plasma clearance or urinary clearance of these endogenous molecule, or the plasma disappearance, or from scintigraphy from the exogenous molecules, or from the urinary clearance, we can calculate the GFR. So most widely used, universally available endogenous marker is the creatinine. But creatinine has some limitation. The level of creatinine will depend upon the body mass, diet, ethnicity, and sex. It has got some tubular secretion. It may vary from 10 to 40%. As the GFR decreases, the tubular secretion will increase, leading to overestimation of glomerular filtration if creatinine is used as an endogenous marker. It's a late marker. To have a significant change in creatinine, at least 50% of the glomeruli should get affected. So it has poor sensitivity to detect CKD also. There are some methodological issues also. There are two methods, mainly there are two methods to assess the blood creatinine levels. First one is the modified Jaffe reaction or the modified Jaffe reaction. The second one is the enzymatic reaction. The modified Jaffe reaction has interference with many chromosomes, which is usually present in the plasma, include the protein, glucose, bilirubin, hemoglobin, and acetoacetate. These can interfere with the Jaffe reaction. The second method is the enzymatic reaction. Enzymatic reaction has the advantage of it won't be affected by these chromosomes. And another advantage is that it can be standardized by the IDMS technique, or called the enzymatic reaction traceable to IDMS. So when you have a particular patient, and if you check the creatinine by both modified Jaffe reaction and enzymatic reaction, the creatinine estimated by enzymatic reaction will be slightly lower than that estimated by Jaffe reaction. So as an answer to main limitations of creatinine, we have another endogenous molecule, cystatin C. It's produced by all nucleated cells and is metabolized by the tubules. It has no tubular secretion or reabsorption. It is not affected by muscle mass or diet, and it has short half-life. but as it has some limitation also. It's assay is expensive, not routinely available. Measurements are not standardized. Level varies in thyroid disorders, liver disease, inflammation, corticosteroid therapy, and in condition with rapid cell turnover. Cystatin C estimated, GFR estimated by cystatin C has found to be superior in case of patient with malnourishment, muscle wasting, and in neonates also. The GFR estimated by cystatin C is superior to that estimated by creatinine. So from the endogenous marker, what will you do? We will calculate the eGFR. eGFR is calculated by the prediction formula. Try to decrease the shortcomings of these variables. The widely used initial formula was 1976 Schwartz formula. Here, the eGFR is equal to K into height by plasma creatinine. K is the proportionality constant. And in the 1970 Schwartz formula, we use different proportionality constant for different age group. From preterm infant, it would vary from 0.33 to, in an adolescent male, the proportionality constant was 0.77. Here, the plasma creatinine was estimated by the Jaffe reaction. Now, in 2009, we have the modified Schwartz formula for bedside calculation, or the CKIT creat criteria. Here, the eGFR is equal to 0.413 into height by serum creatinine. And here we can see that the proportionality constant is same for all age group, and that is 0.413. But you should also remember that the creatinine estimated by this equation formula was by the enzymatic method, not the Jaffe's method. The modified Schwartz formula is more accurate than the Schwartz formula. And in 80% of the patients, the GFR fell within 30% of the measured GFR when measured GFR is used as a standard. And in around 40% patients, the GFR fell within 10% of the measured GFR. So other than the creatine-based formula, we have many other formula also, which may be based on the cystatin C, or other methods, other formulas using creatine alone, or combined formula using both creatine and cystatin C. It's one of the important formula where also called the CKIT eGFR formula, where we use both the cystatin C and creatine. So when you select a particular formula for eGFR estimation, you should be aware that we should look at the original study from which this formula was derived. You should look at the population in which the equation was derived, whether it is a normal child, normal healthy kids, or it was a population of children with advanced CKD or early CKD. What was the age group of these population, and what was the method of assay for the creatinine selected or the cystatin C selected? If we replace these, at least these three variables we should look, and if we replace any of these things, there is a chance of underestimation or overestimation of GFR. As we routinely use the eGFR estimation to calculate GFR in patients, we should be knowing the clinical condition where the eGFR may fail. For creatinine, in case of extreme muscle mass, chronic illness, frailty, high protein creatine supplement, drugs that interfere with the tubular handling, extremely low GFR condition where there is increased extra kidney elimination of the creatinine. In these conditions, the estimated GFR calculated by creatine may not be representative of the true GFR. For cystatin C, in case of obesity, inflammation, thyroid disorder, smoking, steroid use, in these scenarios, the estimated GFR calculated from cystatin C may not be representative of the true GFR. We assume a steady state while selecting the endogenous marker to derive the GFR. We assume the steady state. So in case of non-steady state, these endogenous markers will fail to give accurate GFR, which include acute kidney injury, dialysis, edematous state, etc. So while calculating eGFR and assuming it is similar to the true GFR, we should keep at least these clinical conditions in mind. About the MGFR, we have different methods to assess the MGFR. And one of these is by MGFR by iohexol, MGFR or the measured GFR. Iohexol is a low ionic non-osmolar contrast agent. The plasma clearance of the molecule is calculated after an injection of injecting the iohexol. We will calculate the plasma clearance from the after getting the blood level of the iohexol at particular times. It gives good estimate of glomerular filtration rate. If you have massive edema, the volume of distribution of iohexol may change. In those scenarios, you may have to go for urinary clearance of iohexol. It's accurate than EGFR, but arranging the setting and assessment, all these things are going to be expensive. We have other modes of MGFR estimation by radioisotope labeled molecules like DTPA, iothalamate, EDTA, mercaptoacetylglycine. Again, the issue is that even though they are accurate, they are expensive, and arranging the logistics is also difficult. So from these molecules, either you can check the blood level and assess the plasma clearance, or you can get the imaging by scintigraphy to assess the measured GFR or the MGFR. So you have seen multiple options for measuring the glomerular filtration rate, which one to share, which one to use. So in case of first one is the inulin clearance, it's still the gold standard. It's well used. Then we have EGFR by creatinine, EGFR by cystatin C or combined equation, and we have multiple methods of calculating measured GFR, or you can use the urinary clearance studies also. I already said if you have a malnourished child or muscle wasted patient or in a neonate, cystatin C derived EGFR is more accurate. So in those patients, we will use the cystatin C derived EGFR. And in a general healthy population, there is no advantage of cystatin C over creatinine. So in case of for screening, pre-op evaluation and monitoring of renal function, we may opt for EGFR by creatinine, which is available widely and which is cheaper. So if you are doing a research where you need to calculate an accurate GFR, suppose you are giving a drug and the outcome variable is glomerular filtration rate, where you need to assess the accurate GFR. In those scenarios, we may have to opt for the MGFR. Another scenario is you have a renal transplant donor evaluation. You need an accurate GFR. Here also, we will use the MGFR. If we need to see the differential function of each kidney, there we need an imaging. There we use the scintigraphy. And if we want to see the residual renal function of patient in dialysis, the EGFR or the MGFR may not be representative of the renal function. There you may have to opt for urinary creatinine clearance. So we will jump from the glomerular function to tubular function. In his applied physiology class, Dr. Sudarshan has described most of the functions in detail. So for the completion's sake, I will brush through these topics. The tubular function test include the tubular handling of sodium, glucose, phosphate, calcium, bicarbonate, amino acid, many other molecules also, and the concentrating capacity or the diluting capacity of the kidney, and the acidification test. Then for the diluting capacity, water loading is done, and we'll see whether the patient is able to lower the urine specific gravity to at least 1.003. If the patient is able to do so, the dilution capacity is intact. Urine concentrating test or the concentrating capacity tested by two methods. Either you can use the urine specific gravity or you can use the urine osmolality. The urine specific gravity depends upon the amount of the solute in the urine, or it is called the relative mass density of the urine. Can be measured by urinometer, refractometer, or by reagent strip method. The normal its range values ranges from 1.003 to 1.030. Isocinuria is when you have a urine specific gravity of 1.010, and after challenging, if the patient is able to mount a urine specific gravity more than 1.022, that means the concentrating capacity is intact. Urine osmolality measures the concentration of the osmotically active substances, ranges from 60 osmoles per kg to 1200 osmoles per kg. The water deprivation test is a classic test where you assess the concentrating capacity of the kidney by measuring urine osmolality. Then comes the test for assessment of acidification. These tests are done when you suspect renal tubular acidosis. The battery of tests include the blood gas analysis, blood anion gap calculation, urine anion gap calculation or the urine osmolar gap calculation, then the ammonium chloride test. Ammonium chloride test is the gold standard for assessment of acidification. After the ammonium chloride administration, the ammonia is converted to urea by the liver, and the chloride ions are neutralized by the H+ ions. And then these H+ ions are excreted to the kidney, leading to drop in the urine pH. Urine pH falls below, if the urine pH falls below 5.3, the acidification capacity of the kidney is intact. In case of a renal tubular acidosis, we also do the bicarb loading, and we calculate the fractional excretion of bicarb and the urine minus blood CO2. And condition where we suspect an incomplete ACTA, you can also do the fludrocortisone furosemide test. Most of these tests were described in detail by Dr. Sudarshan in last class. And while assessing the tubular function, we should also be familiar with the concept of tubular maximum of a solute. Urinary excretion of some substance depend upon the tubular concentration, and the tubular concentration of the substance will depend upon the blood level. So most of these substances mentioned are completely reabsorbed and not excreted in the urine. And above a threshold level, the tubular reabsorption capacity is saturated, and these molecules will appear in the urine. Suppose you have some pathology where the threshold falls, then even in the normal blood levels, the molecule will appear in the urine. So the classic example is glucoseuria in case of renal glucoseuria, where the renal threshold of glucose is decreased, and phosphaturia in case of renal tubular acidosis and hypophosphatemic rickets, where the renal threshold of the phosphate is decreased. Moving on to stress test. In presence of an appropriate stimuli, patients with intact nephron mass can increase the GFR and tubular secretion. So here you can see this is a baseline GFR, and after giving a stimuli, the kidney can increase the GFR. So the maximal functional capacity GFR minus the baseline function will give you the renal functional reserve. Renal function reserve in normal adults is around 30 to 70 ml per minute per 1.73 meter square. The stimuli applied are the by oral protein loading or by intravenous amino acid infusion. After this stimuli, there is release of nitric oxide and prostaglandin, leading to vasodilatation, increase in renal blood flow, and increase in GFR. The fall in renal functional reserve indicates that there is silent loss of functioning nephron mass. And now we have the tubular stress test, the acidification test, concentrating capacity, or the diluting capacity test, all are tubular stress test. But the classical stress test that we describe is the furosemide stress test. Here, this is performed in a critically ill scenario child with AKI stage 1 or 2. We will administer the furosemide either 1 or 1.5 mg per kg based on the patient's previous exposure to furosemide, and we observe for a few hours, and if the patient is able to mount a urine output above a particular limit, the patient is furosemide stress test responsive. If the patient fails to mount a urine output, a particular urine output or the cutoff urine output, patient said to be non-responsive, or as furosemide stress test non-responsive. The non-responsive to FST predict stage 3 AKI next 2 weeks with a sensitivity of 87% and a specificity around 85%. Coming to urine analysis, assessment of kidney function is incomplete without assessing the urine. And urine is otherwise called the liquid biopsy of the kidney. You can look at the volume of the urine, if there is any proteinuria, type of proteinuria, whether it is glomerular proteinuria, tubular proteinuria, or there is overflow proteinuria. You can look at the urine for cell cast and crystals, and you can also see the chemical characteristics of the urine for the tubular handling of sodium, creatinine, calcium, phosphorus, magnesium, amino acid, glucose, stone formers, and stone preventers. So these will give insight into the etiology and the extent of kidney disease. With this, I will end my presentation. My main take-home messages are: kidney is a multitasker. Even though evaluation of the kidney function needs a batch test, we often equate the kidney function to GFR. Assessment of the GFR is most useful index of kidney function. The parameter or the variable used, the assay selected, the equation used, all will affect the accuracy of eGFR. MGFR is considered in selected condition where you need an accurate GFR. Assessment of tubular function is performed in unique context where you suspect a tubular dysfunction. And also we should be aware of stress test of glomerular and tubular function, which may give insight to the functional reserve of the kidney. Thank you for patient listening. Thank you.
Thank you, Dr. Christie, for the crisp presentation and keeping to the time as well. And I think we will move on to the next talk by Dr. Abhijit without wasting much time. Over to Dr. Abhijit Saha.
Very good evening to all of you. And at the outset, I thank the ISPN, Dr. Aditi, Dr. Jitender for taking this initiative and inviting us for this wonderful interactive session. I think, Dr. Jitender, it's a one-way thing that the participants can write on the chat box, right?
Yes, sir. You can continue the case discussion. Meanwhile, participant can type their question.
Yeah. So wherever relevant, you can just answer them. I will keep on asking questions. Will it be all right?
They will type it in the Q&A, not in the chat box. Delegates, chat is not enabled for you, but you can type your answers in the Q&A tab. Please do so.
Yeah, fine. So we start with the first case. You can see a picture on the right side of the screen. There is a child who was 5 years of age, presented with facial edema, anasarca, decreased urine output, and pain abdomen. This child was weighing 20 kg and his height was 105 centimeters. And you can see that there is a lot of facial puffiness. Any thoughts? You must be having thoughts about this child by the facial impression only. You can write it in the chat box or in the relevant area. Okay, so the urine analysis of this child was sent and along with the relevant investigations, and it was seen that on the dipstick, the urine protein was 4+, and there was some RBCs, 2 RBCs per high power field. Spot protein creatinine ratio was 6.8. So quantification of proteinuria was done on a spot sample, and it was 6.8. The urea was 100 milligram per DL, and the creatinine was 0.8 milligrams per DL. The sodium was 136 milliequivalents per liter, and a potassium of 4 milliequivalents per liter. Now, the serum albumin of this child was 1.4 grams per DL, and cholesterol was 380 milligrams per DL. So any thoughts on the diagnosis of this child? So you can write on the sections. So
at least 20 people have answered nephrotic syndrome.
Okay, good. So anything else you want to add to the diagnosis of nephrotic syndrome? Sorry, I'm going backwards. Anything else you want to add to the diagnosis of nephrotic syndrome? Or you think it's nephrotic syndrome only? So Dr. Christie told you about the renal functions in this child, and the creatinine is 0.8. So anybody thinks, apart from nephrotic syndrome, which has a diagnostic criteria, you have rightly picked it up, Any spot protein creatinine ratio of above 2 is a nephrotic range proteinuria. Serum albumin below 3 grams per DL is hypoalbuminemia. And along with anasarca, that makes a diagnosis of nephrotic syndrome correctly picked up. So we go further on and see what this child has. So this child also had a raised creatinine. Now you must be wondering that whether a creatinine of 0.8 qualifies for acute kidney injury or not. So the KDIGO definition of acute kidney injury is a small increase of even 0.3 milligrams per DL within 48 hours, or a serum creatinine increase by more than 1.5 times in the previous 7 days, or a urine volume of less than 0.5 ml per kg per hour for 6 hours. They all can constitute acute kidney injury. So if we go back and see here, in this case, the creatinine was 0.8. So presuming a previously healthy child might be having creatinine of 0.4, 0.5, and that is also always available in the age-specific nomogram in various textbooks, you can see that the creatinine is raised over here. Okay. So coming back to acute kidney injury, now since once we diagnose acute kidney injury, we also have a KDIGO staging for acute kidney injury, and that is very important to do while you are managing any child with raised creatinine, because with the acutely raised creatinine, because you need to act simultaneously. Even in AKI stage 1, you can do certain modifications in your treatment plan. So that is very important. So in stage 1 AKI, you can see that there is an increase in serum creatinine from 1.5 to 1.9 times from the baseline. And remember that apart from serum creatinine, there is a urine output criteria. So the child can be fulfilling either the serum creatinine criteria or the urine output criteria, and you cannot miss out the urine output criteria, because it is supposed that if you are missing the urine output criteria, then probably you are missing a proportion of acute kidney injury patients. So urine output criteria is actually more important as compared to the serum creatinine criteria. So stage 2 AKI is 2 to 2.3 times rise in the serum creatinine from the baseline, or a urine output of less than 0.5 ml per kg per hour for more than 12 hours. And similarly, stage 3 is 3 times from the baseline, or an absolute serum creatinine value in a patient above 4 milligrams per DL, or any child who has been initiated on renal replacement therapy. And in patients with who are less than 18 years, a decrease in eGFR to below 35 mL per minute. So can we go back, and you can always calculate the eGFR of this child and then write in the chat box, because I think the height of this child was available to you, and the serum creatinine was also available to you. So you can just write down the eGFR of this child in the chat box. Moving further, now you know that the acute kidney injury could be a pre-renal AKI, or an intrinsic renal AKI, or a post or an obstructive kind of AKI, post-renal, what we call as AKI. So now it is important at times to differentiate whether the AKI is pre-renal or intrinsic renal, because pre-renal is mostly because of the hypoperfusion, and then your management strategies will differ. So in pre-renal AKI, usually the body, since there is a hypovolemia, the body is able to, tries to conserve serum sodium. So the urinary excretion of sodium is decreased, the fractional excretion of sodium is less, and similarly the blood urea creatinine ratio is high. So there is more increase in the blood urea as compared to creatinine. So if you see the for the pre-renal AKI, the ratio of blood urea to creatinine is usually more than 20:1. So the blood urea and the creatinine value of this case is given here. So you can try taking out the ratio of this child and write in the chat box. We move further and we take case 2. Now, this was an 11 years old male who presented with fever for 10 days, burning micturition for 5 days. There was history of febrile episodes in the past. And the mother also gave history that the child has some problems in urinating. She has observed that the child strains while urinating. Now, on examination, this child was pale. His height was 110 centimeters, and his blood pressure was 130 by 100 millimeter of mercury. So this child was stunted because was 11 years old. So you can roughly estimate that the height of a 4-year-old child is usually 100 centimeters, and beyond that around 6 centimeters rise per year. So approximately you can see that the child was stunted. You can always go to the charts and take out the exact centiles. The blood pressure of the child is also raised. So the child was hypertensive, clearly 130 by 100 millimeter of mercury. Some of the investigations which were done in the emergency room showed pH of 7.2, bicarbonate of 16 milliequivalents per liter. The child had a hemoglobin of 7 grams per DL. Potassium appears on the higher side, 5.2 milliequivalents per liter. And this, the urea was also raised. Here the blood urea was 80, but the serum creatinine was 3.5 milligrams per DL. So any thoughts on this child? You can calculate the eGFR of this child and write in the chat box. So with a history of fever, burning micturition, past history of febrile episodes, any history of, and along with history of straining, what all do you have in your mind? What this child can be? This child is stunted and is hypertensive. So you can write your responses on the chat box, and we move further. So the urine examination of this child was done, and it shows WBCs 40 per high power field. You can see on the right side of the picture, there is a multi-sticks which contains numerous parameters which can be easily performed in the ER or right away in the OPD on a freshly passed urine sample. And it also contains 2 parameters. One is known as leukocyte esterase. The other one is nitrite test, which are used for screening of urinary tract infection. So this child was screened for urinary tract infection, and the leukocyte esterase and the nitrite test both were positive. And subsequently, urine culture was obtained. And later on, it was seen that the child had urinary tract infection. So a urine microscopy, leukocyte esterase and nitrite test both are indicated for screening test. Post that, you must send a urine routine microscopy and culture. And remember that the sampling, the collection of the urine is extremely important. You must ask the mother to clean the genitals with plain water or a light soap, and then only collect the urine. And test needs to be sent, and the culture needs to be plated within time. So this child turned out to be a urinary tract infection. Now, combined with the clinical history and I am sure you must have calculated the eGFR by this time, and we move further. So because this child was having obstructive symptoms, he was subjected to some imaging studies, which are again extremely important for evaluation of the kidney functions. And you can see here the ultrasonography picture of this child, the right and the left kidney. You can write the responses, what you think this ultrasound is showing in the chat box. And to begin with, on the left side, you can see there is a dilatation of the pelvic-ileal system. The cortex appears thinned out. Same is seen in the right side of the kidney. So this child is appearing to have hydronephrosis. Now, whether it's only hydronephrosis or hydroureteronephrosis is difficult to assess in this ultrasound, but definitely the child appears hydronephrotic, which is bilateral. So think about a condition where there is bilateral hydronephrosis along with anemia, stunting, and obstructive pattern of illness. And you can write in the chat box your thoughts. So a word about leukocyte esterase and nitrite test. So leukocyte esterase is usually present in the neutrophil, which is assayed by the urinary dipsticks instantly. And with a color change, you need to check your multisticks after how many seconds you need to read that sticks. And with the color change, you can see whether it is a positive test or a negative test. But it needs to be this leukocyte esterase needs to be accumulated in the urine. And that is why at times in smaller infants who void frequently, that it can be falsely negative. Similarly, nitrite test, it detects the bacterial enzyme called nitrate reductase, which converts the urinary nitrate to nitrite. And it is also a very handy test for screening of urinary tract infection. Again, gram-positive organisms lack nitrate reductase, so it detects gram-negative organisms, which obviously are the major causes of urinary tract infection. And infants and small children void frequently. Hence, in infants, the sensitivity is less. But the combined sensitivity specificity of leukocyte esterase and nitrite test is very good. It is as good as doing a microscopy. So now, once you collect the urine, you have to wait for the urine culture, because that will give you whether this child is having urinary tract infection or not. So what is significant bacteriuria? A colony count of more than 10 raised to the power 5 ml of a single species in a midstream clean cat sample is defined as significant bacteriuria. And if it is there, then you will say that this child is having urinary tract infection. Now, asymptomatic bacteriuria is significant bacteriuria in absence of symptoms of urinary tract, which can be seen sometimes in healthy people also. Now, UTI can be simple, as in that there is a low-grade fever, dysuria frequency in the absence of symptoms of complicated UTI. And what is complicated UTI? So any fever above 39 degrees centigrade, systemic toxicity, persistent vomiting, dehydration, renal angle tenderness, or a raised creatinine. So it comes into the complicated UTI. And importantly, any second episode of UTI is taken as recurrent UTI, which has got a very important connotations while evaluating any child with urinary tract infection. Now, there is an image of this child. So this child was having bilateral hydroureteronephrosis, and this child had urinary tract infection. So this child was further subjected to an imaging, and this imaging is depicted on your screen. So some of you can write down if you can identify what this image is about. What is the image? What is the type of imaging it is known as? And what are the findings? In the chat box, and that will be very interesting to note what do you think about it. So this is actually bicturating cystourethropy. And what is it shows is, if my cursor is visible to you, it shows a dilated posterior urethra and the trabeculated bladder. Along with multiple diverticula, you can see multiple diverticula. The bladder is also elongated here. The bladder neck is elongated. And you can see here on the left side, there is a huge dilatation of the ureter showing grade 5 vesiculoureteric reflux. So this child is having obstructive uropathy. And these are, apart from the markers of the blood markers, the urinary markers, there are imaging markers of kidney functions. So one of them is this imaging. So I hope most of you have got the answers correct. And with this, we come to another case, case 3. And this was a 10-year-old male who presented with pain abdomen on and off for 6 months. He had vomiting and acute retention of urine for last 1 day, and that is why he was in pain. Interestingly, there was no history of fever, dysuria, gross hematuria, foul smell in the urine, and or any history of poor urinary stream. There was some past history of passage of 4 to 6 stones in the urine, and the color was reddish brown. So it's evident that this child was having nephrolithiasis, and that is why it was passing stones. Now the stone was reddish brown in color, and there was interestingly no history of renal stone and CKD in the family. So what do you think about this child, what this child is having? And we'll see further what this turns out to be. Now, on examination, this child's blood pressure was high. He was having a blood pressure of 140 by 100 millimeter of mercury. He was dehydrated because he was having pain. He was not taking orally and he was not passing urine. So probably because of that, he was dehydrated. Height and weight of the child was less as compared to his age. His urinary bladder was also palpable, and rest of the systemic examination was essentially normal. So what do you think about the diagnosis, and what additional thing this child, as akin to the kidney functions, what do you think you are dealing with? You can write in the chat box. So we come to the kidney function markers in this child. So the blood urea nitrogen of this child was raised. The serum creatinine was also 1. So what do you think about the serum creatinine? In a child who was 10 years old, 1 is normal, abnormal. And about the serum, the calcium, this child was having a calcium of 8.8. His serum phosphate was 4.5, which is normal. Alkaline phosphatase was 201, serum uric acid was normal. But his routine urine was showing it was full of RBCs, and it showed 10 to 12 pus cells, WBCs. There was no albumin, so the proteinuria was negative. So what do you think, whether this child is having acute kidney injury or whether this child is something chronic? What are your thoughts? So how will you evaluate a child, kidney function of a child who is having, say, kidney stones or say nephrocalcinosis, nephrolithiasis? So this child would definitely require, apart from urine examination, which this child was actually catheterized in the ER and then urine was sent. Serum biochemistry was sent, sodium, potassium, bicarbonate, calcium phosphate, alkaline phosphatase, and the status of the urea, creatinine, and uric acid. So urine analysis was also done for pH, specific gravity, glucose, protein, urine microscopy, for crystals, RBCs, WBCs, any type of cast, then urine culture whenever indicated. For example, this child did not have fever, but had some WBCs. Depending upon the type, quantitative cysteine screening, urine solute concentration in a spot urine, and some concentration after the resolution of the urinary tract infection. You can also estimate certain solutes in the 24-hour urine. Now, imaging is very important part of evaluation of kidney function in a child with nephrolithiasis or nephrocalcinosis for that matter. And ultrasound is very simple. It is easily available. And apart from that, you have non-contrast computed tomography scan in selected cases. Now, since this child, also very important is the urinary crystals. So there are different type of crystals which can point towards different types of stones. For example, dumbbell-shaped or ovoid appearance of crystals is seen in calcium oxalate monohydrate. Envelope-shaped crystals are seen in calcium oxalate dihydrate. Uric acid crystals would be of different shapes like rhomboids, rosettes, etc. Struvite, type of triple phosphate, would have a coffin-lid appearance, and cystine, a hexagonal kind of a thing. But remember what this child had. This child had a reddish brown color of stone passage, which was very friable. So at times you have some rare kind of disease, but usually these are the crystals which are identified in the urine. Now, you need to assess the kidney functions in the urine in terms of, in cases of nephrolithiasis or nephrocalcinosis, in terms of metabolites. So what metabolic abnormality they are having. So you can send certain, metabolic parameters in spot sample, and also the same after resolution of the urinary tract infection in a 24-hour collection. So calcium is one of the very important. So calcium stones are common, and also the nephrocalcinosis. You need to assess the spot calcium creatinine ratio, and the value varies according to the age. Similarly, oxalate, very important metabolite, citrate, cysteine, uric acid, they all can be measured on a spot sample. And 24-hour collection. Now nomograms are also available, normative data in patients with nephrolithiasis and nephrocalcinosis. So coming back to this child, on the right side, you can see NCCT of this child and two red markers there. So you can write what you think about this. Some of the answers are already there on the screen, but you can write your answers as well as to where the stones are, what you think about the stones. So apart from the other things, imaging, the ultrasound, NCCT, other imagings are also available depending upon the case you are dealing with. So this child had a normal sized right kidney, but he had a small right kidney along with a calculi, and on the left kidney also there were multiple calculi. So basically this child had multiple calculi. On the CT, there was a large staghorn calculi on the left renal pelvis with other multiple calculi. So so imaging is again an important marker of kidney function. And coming back to this child, what do you think about the status of kidney function in this child, whether this is acute or this appears chronic? So if you can see here, the kidney size is already affected. So the structure of kidney is altered on one side, right kidney. So coming to the diagnosis of chronic kidney disease in children. So the KDIGO is again given the definition of pediatric CKD. So a GFR of less than 60 ml per minute per 1.73 meters square beyond 3 months with implications for health regardless of the whether other CKD markers are present or not is taken as chronic kidney disease. And in patients who have a GFR of more than 60, if it is accompanied by any structural damage, as you can see in this child on ultrasound, or other markers of kidney function abnormalities, including proteinuria, albuminuria, renal tubular disorders, pathologic abnormalities detected on histopathology or imaging, it all constitute chronic kidney disease. And the chronic kidney disease based on KDIGO is staged into from stage 1 to stage 5, depending upon the GFR, which you can easily calculate with the modified Schwartz formula, which you must have calculated for this child also. So based on the Schwartz formula with this patient with chronic kidney disease, you can write down which stage the patient this patient was. So this the height of this child was 110 centimeters, and he had a creatinine of 1. So you can calculate the eGFR and write down in the chat box whether this child was in stage 1, stage 2, stage 3, stage 4, stage 5. Right? So just 2 slides on the final outcome of this child. So because this child was in pain, obstructive uropathy, there was a large Staghorn calculi, surgeons were involved, and the stone was taken out after a surgical procedure. DG stenting was done, and the composition of stone came out to be 100% 2,8 dihydroxyadenine stones. You can see the red-brown color of the stone.
Thank you so much, everyone, for sharing the valuable insight. We are more than grateful to everyone present here. We hope to have you again on our platform very soon for the next session. With all your permission, we are closing the room, sir. Thank you so much.
I can hear some of the voices.
Jitendra,
Is it?
Is that to end the
Hello.
talk?
Is that
Yeah.
to end the talk?
Hello.
hello Jitendra, what is happening?
Just hold on
Is
a
it a
second.
note to us to end the session, or are we?
No, we have time till 8:30, but we need to quickly finish it in next 5 minutes.
Okay,
because
fine.
we
So
need to do
I'll
post-edit.
just take one more slide to conclude.
Mhm.
So so this child actually came out to be a child with an APRT deficiency, which is one of the metabolic disorders, and which was confirmed by the genetic test, as you can see here. So quickly,
Abhijit,
yeah, I think we can stop
will-
here. Yeah.
yeah, will there
Yeah,
be time for, I
Yeah.
think we have to, the posters and so I think you can wind up.
Yeah.
That will be better.
So you can see with these 3 cases, application of the estimation of GFR in managing day-to-day cases in your clinical practice, identifying with the modified Schwartz formula, the KDIGO definitions of the acute kidney injury and the chronic kidney disease. You can identify the level of kidney damage in patients along with the kidney markers of damage, apart from blood urea creatinine, the urine analysis, proteinuria, the imaging studies, and wherever indicated, maybe for making a final diagnosis, genetic studies as well. Thank you for your attention. I'll stop sharing my screen and hand over the screen to Dr. Jitendra.
Thank you, Dr. Saha. If participants had any question, you can type in Q&A section. We'll try to answer them. Clinic team, please, can you start the post-test quiz?
Hi, sir.
Hi, Sneha. Can you start the post-test assessment quiz?
Sir, the quizzes?
Yeah.
Sir, no need to play the video, sir. Please confirm.
Yeah, we don't need to play video, please.
All
Start
right.
with the
So I'm starting the quizzes, sir. Okay, there will be 30 seconds for each question. And I'll give a countdown, okay? So I'm launching the first question. Is it visible?
Yes, it is visible.
Yes, it's visible.
"15 seconds. 20 seconds. 25 seconds. 30 seconds. Time up. Moving to the next question. It's visible. Question 2.
Yes.
10 seconds. 15. 20. 25. 30 seconds. Time up. Moving to the next question. 10 seconds. 15 seconds. 20 seconds. 25. 30 seconds. Time up. Moving to the next question. Ten seconds gone. 20 seconds gone. 30 seconds. Time up. Moving to the next question. Ten seconds up. Striking at 20 seconds. 30 seconds down. Time up. Moving to the next question. Ten. 15. 20 seconds down. 30 seconds. Time up. Moving to the next question. Ten seconds gone. 20 seconds gone. 30 seconds. Time up. Moving to the next question. Ten seconds down. 20 seconds. 30 seconds gone. Time up. Moving to the next question. Ten seconds up. 20 seconds gone. 30 seconds. Time up. Moving to the next question and the last question. Ten seconds up. 20 gone. 30 seconds. Time up. End of it, sir.
So is it possible
Thank
the
you.
icon that says share results will share results to the participants?
Just a moment, ma'am. It will, ma'am, as you can see, there are different questions. So I have to fetch
Right.
each,
All right.
yes, each question's
Sure.
result, ma'am. That's the problem.
Sure.
I need to curate that
That's
and
all.
I can send it to you by
That's
tomorrow.
perfect. That's all right. Dr. Susan has her hand raised. Susan ma'am, Dr. Indira ma'am, do you want to say some closing comments?
Yeah, I am really impressed by both the presentations, and I hope the students have really gained out of it. It was both the presentations were simple, lucid, and really covering the topic in a nice manner. And are we getting some feedback from the
I think
students?
there
Are we getting
there
it?
are
Yeah,
one or two question in Q&A
chat box
section.
Q&A. Okay, and pertaining to the conduct of the program, I think we should be getting some feedback from the students so that we can incorporate some changes if it is required and move ahead. Okay, so the questions, is there time for discussion, Jitendra? Or
Yeah, we probably have 5 minutes, ma'am, before we can close it.
okay, so
There was a question there, child. Can
Yeah.
I read out one question?
Yeah,
That
yeah,
child
you.
with loin pain, ultrasound KUB was suggestive of renal pelvic stone. Child had renal angle tenderness, no fever. Will we consider complicated UTI and start empiric antibiotics in case, or manage without antibiotics on line of nephrolithiasis? Would you like to answer that, Abhijit?
This was a very sick child in the ER and was taken for the operative intervention. So it's little complicated. So anyways, he was to be given antibiotics, but as such, there was no indication. The child did not had fever. There was no pus coming out of, I mean, he had actually obstructive symptoms. So as such, it was a plain case of nephrolithiasis. So it depends on, for as far as this child, he did receive antibiotic because he was taken to the OT. But as such, for urinary tract infection, there was no need for it because this was a case of nephrolithiasis without urinary tract infection.
I think I can see only that question in the QA box.
Yeah,
I
what
think
was the
rest are all
diagnosis for
answers.
Yeah,
So
what
the
was
diagnosis I told you was APRT deficiency. It is one of the enzymatic deficiencies which leads to 2,8-dihydroxyadenine stones. There is a defect in the conversion of adenine to other metabolites, and the xanthine dehydrogenase enzymes, it converts adenine into 2,8-dihydroadenine stones. And that gives the characteristic reddish brown color to the stones. And you can treat this patients using allopurinol or febuxostat, which is an inhibitor of xanthine dehydrogenase enzyme. So this child is almost now he's 18 years now. When he was diagnosed, he was 10 years, and he is doing fine. He is a chronic CKD. There is little increase in the creatinine, but as such, he is fine.
Thank you, Abhijit. I think I would also like to just pass a comment. Both the talks were excellent. And I think especially Christy really brought out all the different methods of assessment of renal function. It was very comprehensive. And I think Abhijit tried to show through his cases situations where it could be acute kidney injury as against a chronic kidney disease. And I just wanted to point out that in the first case with nephrotic syndrome, though I think majority did mention it was AKI, but a few students also mentioned it as chronic kidney disease. So I think it's just important to remember it's not just a creatinine value that tells you the diagnosis. You have to look at the whole history in toto and also look at especially the growth parameters, I think, which were very clearly highlighted by Abhijit in his cases. The first nephrotic was a well-grown normal child. Somebody asked if we didn't have a pre-existing creatinine. That's true. Sometimes we won't have a pre-existing creatinine, but you have to take the clinical picture as a whole. In the second child, he very clearly showed that child was stunted and had growth retardation. So that gives you a clue on to chronic kidney disease. So, and then your supporting investigations will give you a clue. So it's not just the creatinine value per se, which tells you is it acute or chronic. I think one has to take the whole clinical picture into consideration. Every single parameter that he had mentioned has some value. You might have hypertension both in acute kidney disease as well as chronic kidney disease, but many times it's the clinical scenario as well as the growth parameters which might give you a clue. And of course, your ultrasound and all other investigations. So I think, yeah, there weren't too many other questions. So I think maybe the topic has been very clearly and nicely covered by both the speakers. I'd like to congratulate both of them.
There is one more question in the chat box. Why
Is it?
DTPA
Okay.
scintigraphy not a good standard for GFR estimation? Dr. Christie? Dr. Christie, would you like to answer?
Ma'am, usually for patients where we need an accurate GFR, we do the plasma clearance studies of the exogenous markers like iothalamate, iohexol, etc. DTPA scintigraphy, here rather than injection or after the injection of the DTPA, we need to assess the imaging. We should count by the Geiger counter, we will count the radioactivity and by which the GFR is measured. So scintigraphy will be the plasma clearance will be preferred over scintigraphy. Hope that is the answer.
Okay.
So before we close the talk, I can see the Professor Bagga there. Sir, any comments from you? Bagga sir, I think. I think sir is probably left the
Sir,
session
should I send
already.
unmute request to Bagga sir?
That's okay. Might be having some difficulty with his audio. It's okay. I think we are at closing time. We should just close, I think.
So with all
Thank you very
your
much.
permission, ma'am, can I close today's session?
Yeah, thank you.
Jitendra,
Yeah.
yeah.
Yes,
ma'am.
yes,
Jitendra,
ma'am.
can you tell about the next session, the speakers and the topic, and before we wind up and close?
So next session would be on evaluation of children with hematuria. So we'll be having on next Friday. Yeah.
Okay, now I think we can close. Yeah.
Yeah, yeah.
Thank
Sir,
you
ma'am,
very
and
much.
the session and event flow will be same as today, like
Yes, yes, yes. The
Yes.
flow of event.
all right,
Same.
definitely our team, my colleague will definitely get in touch with you to get the entire flow, and if there is any other changes, we'll definitely get in touch with you, ma'am. So
Thank
with all your permission, ma'am, I would like to thank everyone sharing their valuable feedback, valuable insights. We are more than grateful to everyone present here. We hope to have you again on our platform on next Friday. With all your permission, ma'am, I would like to close the room.
Thank you.
Thank you very much.
Thank you
Thank
so
you.
much, ma'am. Have a
Good
good
night,
night. Have a
everyone.
healthy
Thank
week
you.
ahead, ma'am. See you on next Friday.
Thank you. Thank you.
Thank you, everyone.
Thank you, ma'am. Thank you, Aditi, ma'am.